Hi guys, welcome back to the new episode of our A to Z series, and today let's quickly revise Juvenile Nasopharyngeal Angiofibroma in a tabular form. Juvenile Nasopharyngeal Angiofibroma is a benign, locally aggressive and extremely vascular tumor. It occurs commonly in young adolescent males. Let's move ahead and talk about the site of origin. The most common site is sphenopalatine foramen. The other sites include anterior wall of sphenoid sinus, roof of nasopharynx, and lateral wall of nasopharynx. Now let's talk about the clinical features related to this. First, we have bleeding. Recurrent unprovoked profuse epistaxis is observed. Next, we have nasal obstruction and eustachian tube obstruction, unilateral serous otitis media and conductive hearing loss, frog face deformity, which includes proptosis, broad nasal bridge and swelling of cheeks, hyponasal speech. Next, we have cranial spread, which includes cranial involvement of 2nd, 3rd, 4th, 5th and 6th cranial palsy. Extension into sphenoid and cavernous sinus causing nerve palsies is observed. So what are the clinical examinations related to this? First, we have anterior rhinoscopy. Globular pink mass in the posterior part of the nasal cavity is observed, septum being pushed to the opposite side. Next, we have posterior nasal examination. In this, pink to purple globular mass with dilated blood vessels are observed. So now let's understand how juvenile nasopharyngeal angiofibroma is diagnosed. First, we have plain X-ray and CT scan. In this, anterior bowing of posterior wall of maxillary sinus is seen, and this is known as Hallman-Miller sign. Next sign we have is Hondusa's sign. Here, increase in the distance between maxillary sinus and mandible on the CT scan is observed. Next, we have CECT scan, and this is the investigation of choice for this disease. Next, we have MRI and angiography to know the vascularity of the tumor. Now let's talk about the staging done in juvenile nasopharyngeal angiofibroma, and it is called as Radkowski staging. The first subtype is stage 1A. It is limited to nose and nasopharyngeal area. Next we have is stage 1B. In this there is extension into one or more sinuses. Then we have stage 2A. Here there is a minimal extension into pterygopalatine fossa. Then we have stage 2B, occupation of the pterygopalatine fossa with or without orbital erosion. Next we have stage 2C. Here in infratemporal fossa extension with or without cheek or pterygoid plate involvement is present. Then we have stage 3A. The erosion of the skull base is seen. Last we have stage 3B. Here, erosion of skull base with intracranial extension with or without cavernous sinus involvement is present. So let's end our today's discussion with discussing about the treatment of juvenile nasopharyngeal angiofibroma. First option we have is surgery with preoperative embolization, and this is the treatment of choice. Next, to decrease vascularity, embolization 24 to 48 hours before surgery is done, a course of estrogen therapy, stilbestrol 2.5 mg thrice daily for 3 weeks is given. Then, cryotherapy is performed. Next we have is radiotherapy, which is done only for stage 3B. And last we have is hormonal therapy and chemotherapy, which is as such not in use now. And yeah, that's all for today. Thanks for watching and see you in my next episode, which is going to be episode K. And yes, if you have still not liked this video or subscribed to my channel, please don't forget to do that.